You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites on iTunes, and you can also follow us on Twitter at ASAM.org and Facebook. Now let's go beyond the abstract. Welcome back to another episode of Beyond the Abstract. We sure do appreciate you stopping by. Today we've got a great talk with Dr. Nabila El-Bassel, who joined us to discuss her new research article, Artificial Intelligence and Stigma in Addiction Research, Insights from the Healing Community Study Coalition meetings, which was featured in the current March-April edition of the Journal of Addiction Medicine. We got to talk about stigma in the context of MOUD and addiction care, as well as the advantages and potential concerns about utilizing AI-assisted methods in research and why the human-centered approach to AI is so important. Now a little bit about our guest today. Dr. Nabila El-Bassel is a university professor at the Columbia University School of Social Work and director of the Social Intervention Group, a research center on intervention and implementation research on addiction and co-occurring issues. It includes HIV, violence against women, and mental health. She is a globally recognized leader in addiction, HIV, and implementation science research, and she has led numerous large-scale federally funded studies in the United States and internationally, including serving as principal investigator of the Healing Community Study, the largest community-based study to address the opioid crisis in the United States. Her research centers on stigma, gender inequities, and structural determinants of health, such as poverty and policy barriers, as key drivers of addiction, and she has published more than 400 peer-reviewed scientific papers. All right, now let's get into today's talk with Dr. Nabila El-Bassel. Again, I want to thank you so much for taking the time to sit down and talk with us today. I'm looking forward to our conversation. I want to start, we kind of always start with a simple question of why addiction medicine, why this field? Tell me a little bit about what it was that introduced you to addiction medicine and got you interested in it, and why this field of all things. What's your experience been like up to this point?
Okay, first let me say thank you for having me. I'm an addiction social behavior researcher, and I was drawn to the field of addiction for three interrelated reasons. The first reason, I wanted to better understand how structural drivers such as stigma, poverty, homelessness, incarceration prevent people from accessing addiction treatment and harm reduction programs. The second reason I was drawn to the field, because addiction is also a global public health issue. And I always have been interested in global health research, including addiction and co-occurring issues, challenges like gender-based violence, HIV, and sexual transmitted infections, and how they related to addiction. But I also know that addiction is shaped by differences in drug markets, drug policies, and healthcare system across country. And this broader context, in the global context in addiction, really have been one of my important area of research and work. And that's why I was drawn to addiction research. And the third one, and the last reason, I was drawn to addiction social behavioral research because it allows me to engage in research that is grounded in community voice and in the experiences of people with lived experience. In my research, I believe in co-designing addiction interventions with the community so they are better aligned with their lives and real contexts that they live in. So these are really the three reasons that led me to become a social behavioral addiction researcher.
Amazing. I love it. Well, I want to shift into asking you a little bit about the study we're here to talk about today. And my first question, your study found that stigma was frequently mentioned in the context of MOUD, medication for opioid use disorder, compared with other evidence-based practices such as opioid overdose education and naloxone distribution. So tell me, what are some potential reasons for stigma being discussed more in the context of MOUD use and delivery compared to other evidence-based practices?
I have to start by saying I really was not surprised with these findings because MUD is still widely misunderstood. Even though a medication for opioid use disorder is evidence-based medication for people who use drugs, many people still misunderstand them as simply they think the MOED medication for opioid use disorder replacing one drug with another, than really recognizing them as legitimate addiction treatment. Some people, in fact, still believe that recovery means stopping use of all drugs and treatment and relying only on willpower. So when someone takes a medication like methadone or bute, people see them as still not in recovery, and they see them as really people who cannot stop using drugs, instead of seeing them as using medication that helps them to survive, helps them to cope, and they're in recovery because they want to be on medication to go back and live their lives. The other issue that I was not surprised to see this finding. Unlike naloxone, MUD is often naloxone is often used in a single emergency moment. They give them to survive. And where using medication for opiate use disorder, people require repeated interaction with the clinics, pharmacies, treatment programs, and where there they experience really a lot of stigma. So to me, MUD raises broader questions also about addiction recovery and who deserve care. It's often it brings really deeper beliefs about whether addiction is treated as health condition or a moral failing. And that's why MUD tends to generate more discomfort and more stigma than other evidence-based practices like naloxone.
That's interesting. Your study also found that counties with a greater proportion of minoritized populations were actually more likely to integrate discussions of EBPs with stigma-related issues. So tell me, how can your findings about stigma maybe inform efforts to improve MOUD access and reduce those barriers to MOUD access across communities?
First, let me say that this finding needs to be explained very, very carefully. It does not mean that counties or communities with larger minoritized population are more stigmatizing. Rather, it suggests that in those communities, our coalition members in the healing, like what we found in the healing community study, maybe seeing more clearly how stigma and inequity overlap in real addiction system of treatment and care. And so we also know from the literature, and we cannot ignore it, that stigma is often more layered for people of color. Substance use stigma can be a greater barrier to treatment for Black and Hispanic clients, especially when it overlaps with racism, poverty, or criminal legal involvement. That kind of overlapping stigma can make treatment much harder to access and stay in it. So the medication is that improving access to MUD requires an equity approach, requires really more attention to people who cannot access them, especially a community of color. And it cannot be only a broad message about reducing stigma. We have to reduce stigma. It has to focus on places where stigma exists, like drug treatment programs, healthcare system, pharmacies, and other systems that the people who use drugs interact with. This is why we really need to think broadly about the mission of reducing stigma. We have to reduce policies that really stigmatize people. We have to integrate stigma reduction in all the systems where people who use drugs interact with. And that's really the implications of one of the major findings of our work, is really broadly to address stigma. I have to really give an example. The healing community study is the largest community-based research that we conducted recently. And one of our mission to reduce stigma is to generate communication messages to broader communities about what it means to be on drug use, what it means to be a person of color on drug use, and how the community is looking at you. So my really message from the research that we did is we need to look at stigma in very, very broad context and address it in many different contexts. That's really what one of the major implications of our research.
Well, and you're kind of already touching on my next question, but I wanted to look ahead a little bit and ask you about the future. So what future research questions did emerge from this study? And what do you think in terms of other research studies, how would that be able to kind of address those questions and resolve some of them?
That's a really good question. And one of my major questions that I'd like to study, to what extent do coalition discussions that we measured on stigma in the healing community study predict actual deployment of evidence-based practices? And also when you look at quality of implementation and sustainability of evidence-based practices over time in relation to stigma. This is really, to me, it's the strongest next question, because the paper shows that how often stigma was discussed, but the larger next step is testing whether those discussions actually shaped implementation outcomes. I have another question that I'm really curious and I want to test it. The healing community study deployed communication campaigns to reduce stigma in the community, in 67 communities. The next question is, how do stigma-related discussion that we have found changed over time, especially before, during, and after rollout of the stigma reduction campaigns that the healing community study designed? This is really an important question that we did not have a chance to test when we implemented the research. So this is my next one. And the last one I want to say, can AI that I use in my paper can be used really during the time of the implementation of the research and not post the implementation of the research?
Mhm.
This is the best really AI-focused question, because the paper contributed significantly in how we can use the data post implementation of the research. But I would like to really look at how AI can be used during the implementation of the research.
That's actually, I wanted to shift gears and ask you about this, specifically about AI assisted methods in research. So talk to me about some of the advantages and concerns. Let's start with the advantages. What do you feel are some of the upsides of using AI assisted methods in research, and specifically when we're talking about like qualitative and community engaged research?
That's really a great question. I would have to start by saying AI can help researchers to work much faster. In qualitative and community engaged research, we often deal with large amounts of data. We use in-depth interviews, focus groups, field notes, intervention fidelity measures, and community feedback. And in most cases, unfortunately, researchers do not have the time or the funding to use all this data, to analyze the data. And therefore, we leave the data and we don't use it after we collect it and spend so much time. So AI can help researchers to work faster and to even bring back the findings to the community faster. The second, AI can make research more responsive in real time, which I really want to do it. It's my next study. Using AI can be useful during the implementation of community engaged addiction research. It allows the researchers to learn from the data while the research is still happening. So during the delivery of the intervention or during the implementation of the research, if participants are raising concerns about trust, access to care, or cultural relevance, those themes can be identified as early as possible during AI and can improve the delivery of the intervention and implementation of the research. And the last point I want to make, AI in most valuable use is when humans stay in the loop. What I mean by that, AI can support the work, but it should never replace a human judgment. Researchers and community partners still need to expand the findings, need to look at the outputs of the findings, make sure the meaning truly reflects people's life's experience. AI can detect patterns quickly, but it cannot fully understand the context and human lives. So it's really very important that even when we use AI, to always reinforce the human stays in the loop, and I'm talking about the interrelationship between how AI use and human in implementing the research and collecting data. That's really an important message for people who are interested in using AI in community engaged research and implementation research.
And you just mentioned the importance of having that human-centered approach where it's still part of the AI kind of whole process here. So now talk to me about some of those concerns. You know, if we lose that, if there's not that human touch that's still involved in it, what are some of the concerns about implementing AI in research? And you know, in that sense, can you tell me a little more about how that human-centered approach to implementing AI into research can really help ease some of those concerns?
As I mentioned earlier, although AI offers real advantages in research, especially by helping researchers analyzing large amount of data quickly, it also raises important really issues that can fast the researcher season. But there are some important concerns that I want to raise. AI can reproduce bias if the data are incomplete or don't include data on all different populations. Second, it also can miss context, meaning of like the real life, the cultural context. And that's really a dangerous thing to rely on AI if it doesn't really capture the context of people's life. Third, it can misunderstand meaning that are really the AI cannot capture them. It's like if people talk about cultural context, they talk about using language that it's AI cannot capture. It's really focusing on only AI may really lead to dangerous really decisions and implications. And the other piece is also we have to be very careful because AI has really issues of privacy, consent, transparency, and whether the community truly understands how AI is being used. Those are issues that we need to be very, very careful. But I want to also say, when human is involved, we can address many of these issues. And I promoted the concept of a human-centered approach. A human-centered approach means AI should support the research, not replace the human judgment. Researchers, data scientists, clinicians, and community partners in research all need to stay actively involved in questioning the data, explaining the findings, and asking whether the output actually makes sense in real world. Also, I want to highlight, in other words, human needs to stay in the loop, meaning in addiction research, we cannot just accept our outputs at face value. We have to ask what may be missing from the data. Does this pattern that we're seeing reflect the need of the population, or does it reflect biases? And who gets documented, whose data is involved? All these issues really only can be integrated if a human stay in the loop and AI and a human really work together. But that's really where I see the importance of AI-human interaction.
Well, this has been a really interesting conversation. I want to thank you again. And as we come to the close of our show, we're going to shift gears completely. And I want to ask you, you know, you've been such a wealth of information and knowledge today, but I want to ask you for just a little bit more wisdom, if you could. And I want to ask for what kind of advice or wisdom would you share with the up and coming generations of addiction medicine providers, maybe those just finding the field or those, you know, just deciding this might be something that they want to pursue? What do you wish you knew when you started, and what do you think that they should know?
Yeah, this is really a great question. Thank you for asking me this question. First, I want to say to the new generation of addiction medicine researchers or clinicians, it treats stigma as real barriers to care because the stigma can keep people from entering treatment, stay in treatment, and feeling respected in the process of getting treatment. Second, I also want to say that always assess for MOUD stigma directly and make sure equity core element to be part of this effort. That means creating space for the clients, the patients, to talk openly about stigma, recognizing how it may affect the trust and treatment decision, paying close attention to the fact that barriers to treatment often fall more heavily on Black and Hispanic and other marginalized communities. So really stigma is important to be looked at here. Thirdly, I would say use AI to support learning in both practice and research. For addiction physicians, that could mean using AI to spot quickly patterns in treatment access, retention in treatment, missed follow-up, or barriers such as stigma around medication for opioid use disorder. The goal is to strengthen care and clinical decision, but not to replace really human. It's really the same notion of AI can interact with the human to address these issues. And the fourth thing I want to say, use AI to strengthen addiction research. It's really important to think about this, especially in community-based research. But again, always keep humans in the loop. AI can help the researchers to analyze interviews, to analyze focus group, to take a call, to analyze coalition notes and other real-world data more quickly, and can identify stigma and barriers to accessing care and gaps in treatment, but always stay in the loop as a human, as a researcher or clinician. You work with AI and a human in the loop, human-AI interaction. For the new generation, I would say it's really very important to consider.
Dr. El-Bassel, thank you so much for your time today. It's been a great conversation.
Thank you.
This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. And remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.